Hello, everybody. This is Susan Clinton, one of your hosts for Tough to Treat. Thank you for joining and listening today. We have a really great case to talk about. It's kind of an interesting look at urgency and urgency incontinence in a postpartum female, especially since there's kind of a musculoskeletal driver to her urgency. Have a listen, give us some comments, and thanks always for being part of our podcast. Hello, everybody. This is Susan Clinton and my co-host Erica Mello, and we are Tough to Treat. Hello, Erica. How are you today?
I am good, thank you. I have a bit of a cold, so I may have come out a bit of hoarse voice for the listeners, but it's one of those things. So I apologize.
Not a problem at all. At the time of us actually filming this podcast, we are one day past Thanksgiving, so I think all of us have a little bit of holiday recovery going on, and kind of clearing the decks and getting ready to move on into the activities and whirlwind of the end of the season. So it's great to be able to kind of sit up here in my office and speak with you this morning about a patient that I think is a little bit on the complex side for some of the ones that I see. And I thought I would share it with you and the listeners and get some input on a few things with her.
Perfect. Let's go.
Yeah. Okay. So it's a 34-year-old female that is postpartum by 4 months with her first child. And she put herself on my schedule mainly because she's having problems with her right hip, her right pelvis posterior, a little bit of pain with intercourse. And but the biggest problem that she's really dealing with is some urge incontinence, which she says is very mild, but reports it's happening 2 to 4 times a week, usually in the evening at home, when she's fairly quiet, not a whole lot going on. So she doesn't report any incidences at work. She's a busy healthcare worker and doesn't report any incidences at work. So that's kind of the background. That's where she came in with. After doing my usual amount of questions, did you have pain in pregnancy? The answer was yes. More so at the last trimester. The belts were uncomfortable. She didn't like wearing them. She didn't really try a pregnancy support band. She wasn't sure what to get, so she just kind of muddled through with everybody telling her that it'll be better after you have your baby, which, my soapbox is like, no, don't tell people that. Let's care for people where they are, and let's don't tell people it'll get better after you have a baby. That's crazy. Anyway, she did not have any problems with any incontinence at all during her pregnancy. Zero, none. She had a vaginal delivery.
Got it.
Did have some tearing, and reports that they did do stitches to repair the tearing. Denies any problems with her bowels whatsoever. She says she's not straining. She doesn't feel like she's constipated. She does have a small bowel movement every day, and so she, has said that all of that is working back there. Those were her words. She also reported that in order to get pregnant, because I asked her, I said, well, what about pre-pregnancy, and how have you been before that, and any accidents and injuries and, things like that. She had no real accidents or injuries, certainly no motor vehicle accidents to speak of. Prior to, in her past life, she said she's had a kind of an issue with the knee once on the left side, some small joint stuff. And so that kind of perked my ears up. And it's like, small joint stuff? What do you mean small joint stuff? Well, just small joint pain. And I said, well, do you know why you were having small joint pain? And she goes, oh, yes. The people, the questions that they think are relevant, or the answers that they think are relevant are really relevant, but they don't think they are, which is really funny. So she has autoimmunity, and one of the expressions of her autoimmunity is celiac disease. And so when she found out that she had celiac, she started, went, completely gluten-free, and that seemed to have solved most of her small joint pain. But she said, she hasn't since she got pregnant and since her pregnancy, she has not been working with anybody like an endocrinologist at this point. She did say that she started having migraines in her pregnancy, and the migraines seem to be a little bit better now, but she did take herself to a neurologist because she was having not only migraines, but migraines with a lot of the electrical lights and things flashing in her eyes. So she got concerned about that and did go to a neurologist.
Okay.
Which I thought was very interesting. And, she said they would last about 24 to 30 hours.
That's long.
And then, it is pretty long. But then they would be kind of a lot of space in between. So it wasn't something, and of course being pregnant, it wasn't something that's going to cycle with hormones and, things like that. Was it hormone-induced migraines? Not sure.
Right.
Nobody is really sure at this point. The neurologist told her that there would be changes in her migraines after she had her baby, and let's just see what happens, and we'll go from there and keep working. So she said that she's had a few migraines, much less in frequency and much less in intensity since she had her baby.
Okay.
So she feels very positive about that, but she is still getting the headaches. And, of course, she has a lot of fatigue because she's got a baby at home. And she's still breastfeeding. She's having trouble with milk production a little bit. So she's feeding a little bit more often in order to try to get that boosted up. And there she is. And so when asking her about her main issues and the main things that she wanted to concentrate on, she said, well, I'm here mainly because of my pain, but also the urge incontinence. But since you brought all this other stuff up, all of these things are of a concern to me. So everything was on the table, which was great, because whenever I hear the word urge incontinency or urgency frequency, I start thinking about, okay, if I'm going to think about the nervous system, I'm going to think about the upper cervical area, craniovertebral area of the cervical area. And especially with somebody with migraines too, it's like, a lot of stuff going on there. It sounds like maybe, but I also wanted to find out what she was doing diet-wise and what also was happening with some other things that were going on in her life too.
Right.
So we started talking a little bit about, what does it look like? What does your day look like as far as food goes, as far as eating? What's happening? Well, she's drinking 2 large traveler mugs of coffee in the morning, which is interesting. But that goes along with the fatigue. Why are you drinking the coffee? Because I'm so tired. Go ahead.
Question on the urge incontinence. She just gets it in the evening, you said, right?
Yeah.
Okay.
I know. Very interesting, right? I would expect it like, right after you drink that coffee, I bet you have to run to the bathroom.
And you would think since she's a busy healthcare worker, she wouldn't have time to go to the bathroom, right?
Exactly.
Interesting.
And finally admitted that she has been withholding water during the day because she didn't really want to have to deal with, stopping to go to the bathroom as much. The coffee is definitely there because she feels so tired.
Yeah, of course.
Because I've been a bit of a coffee drinker always, just a cup in the morning, but she really admitted to, when I asked her, she said 2 cups of coffee a day. When I asked her, how big are those cups? And she showed me the traveler's mug. It was like, okay,
that's a lot.
You're actually getting probably close to 32 ounces of coffee in the morning, not just 8 or 12 or maybe even 16. I mean, you're really getting a lot. And she started talking a little bit about that, and then she started talking about her diet and went off a little bit and said that, she's just, having a couple of snacks here, and, she doesn't really take time for lunch. And so she eats, a quick bite of this here, maybe a small salad here. And, so very little protein going into the system at all. And this is a 4-month postpartum mom that really needs a lot of nutrition to keep her system up. And reported that she actually had a lot of trouble getting pregnant.
I was just going to ask that, actually.
Yep, I know, right? And she said that so she actually had to increase her protein by a significant amount.
Oh, interesting.
In order to get her into a situation to where she was able to get pregnant. That was the first
So
thing that
no
they
in
looked at
vitro
was
or anything like that, right?
right, right.
Right. Okay.
Yeah, they didn't have to do IVF. They didn't have
Mm-hmm.
to do any egg retrieval or any of those types of
Mm-hmm.
things, which is
Yep.
great. But she said she had to significantly alter her nutrition to get pregnant.
Hmm.
And then for whatever reason, being a busy healthcare worker and stuff like that, yay, I'm pregnant. I don't have to think about it anymore. Kind of let that drop off. So she was interested in listening to, oh, maybe I need to do something to support, a little bit,
Yeah.
more nutritional stuff. And so I asked her, I said, are you really, are you trying to be vegan? What is your goal here? And she said, well, I think that's kind of where I like to, I feel more comfortable sitting, kind of with most of my feet in the vegan world. And so we talked a little bit about that. I would support her being a vegan, that wasn't a problem for me. However, she probably isn't going to be able to get enough protein in the vegan world right now to get her through her postpartum thing. So if she could think about supplementing her protein for a while, and then, as she gets healthier and feels better and stronger and she's past the, her postpartum time, that she could, kind of be able to sort that out a little bit better and probably do very well with vegan protein. But oftentimes in times of stress, I have women with autoimmune that if they stick to vegetable protein, oftentimes they don't get enough building blocks of the stuff that they need to repair and recover during these times. And, postpartum is a huge time for autoimmunity markers to turn on.
Yeah.
So especially since she already has some autoimmunity, this is a prime time for her to really, really, really make sure her nutrients are going in, that she's got good nutrient dense food and things like that. So we paused to speak about that a little bit, which was good.
Is she like a teeny person, or she's big or average?
No, she's average. She's very tall, but not lanky. So
Okay.
she's tall, but you know what I'm saying. She's a little
Yeah.
bit. I would have to say, if I had to like describe her build, if you know how you look at Amazonian females on the volleyball court.
Mm-hmm.
They're tall, but they're,
Mm-hmm.
strong. They
Yep.
have that build.
Yep.
She has something like that. She looks a bit like that.
Okay. And how heavy was what was the birth weight of the child? Was it?
The baby weighed 8 pounds and 3 ounces.
Okay. Okay.
Yeah, so not bad.
Not bad. Yeah.
Enough to cause some tearing. She didn't have
Yeah.
prolonged laboring, in the second phase. So she wasn't doing a tremendous amount of pushing and straining, which was good.
Mm-hmm.
Her pregnancy, other than the pain and the headaches, was pretty normal. And the
Yeah.
baby was certainly normal all the way through, which was
Yeah.
good. So all of that was good news and good stuff. And so now we're kind of left with this little bit of what I would almost call, I don't like to use this word, but she's bordering a little bit on what I would call some fragility
Yeah.
around the edges of her postpartum time. And part of that is nutritionally driven. The other part that's driving a little bit of that is like that excessive amount of coffee in the morning.
Mm.
So instead of getting some nutrients in to power her through her day, she's kind of relying on coffee to do
Right.
that. That's
Right.
her thing. She wants to do that. It's easy, it's fast. She can get her son to daycare, get out the door, and get to where she needs to be.
Right.
So I understand the method behind it and the madness that goes with the method, but for her, it makes me wonder a little bit about her migraines too, how much the coffee might be, kind of
Yeah.
a piece
Yeah.
behind that as well.
Yeah.
So we talked a little bit about, don't stop all your caffeine at once. It's not a good thing. You're gonna,
Right.
you're gonna,
Mm-hmm.
you won't be a happy person, and the people around you will not be happy. Caffeine is a drug. Let's bring it
Mm-hmm.
down a little bit at a time, but let's, so we started with the second cup. She made the decision, I said, can you fill the second cup up only halfway? And, so she kind of figured out, yeah, what I'll do is look at a smaller second cup. And I said, but you need to replace it with something. So she decided that she liked things that are hot. So she would start kind of playing around looking for maybe an herbal tea or something to stick in her travel mug
Mm-hmm.
to have with her. So we got that going and talked a little bit about that. And I sent her some resources on how to, get some more nutrient dense meals going and to get that protein, situation up a little bit, maybe even some collagen powder to kind of help with tissue repair
Mm-hmm.
and that kind of part in the postpartum era. So we got that part going, which I think is going to be very helpful for her.
Mm-hmm.
So then the next part was to like look at her. I mean, here she is with me with, hip pain and some posterior pelvic pain. So she would like point to the back, not really the SI, more the glute muscle mass back there. That was mild. The right hip pain was kind of inconsistent. She was, worried that if there was something going on in her hip joint.
Yep.
And, she did speak about, pain with sex. So she said that still is very uncomfortable. And I'm not sure why. We've tried all the different kinds of lubes and it hasn't helped. So it's not I said, well, do you feel like it's a lubrication problem? She goes, no, I don't feel like it's that at all.
Yeah.
And I said, well, lubrication will make it slip a little bit, but it's not going to, solve the pain issue probably as much.
Are there any other positions or postures that made her hip worse or pelvis worse?
Oh, yeah, of course. So the missionary position is the worst.
Okay. And then what about just standing, walking, sitting, things like that? Did they
So we talked about that. Walking seemed to be okay. Standing and stooping is no bueno. Didn't like that at all, and doesn't really like to be in that position very much. And so that's a problem. If she sits for a long period of time, when she goes to stand up, it really bothers her.
Right.
So it doesn't really hurt when she's sitting or she doesn't think about it, but when she goes to move to get up, and so how long can you sit before those symptoms come on? And she hadn't really even thought about that at all. So, we were sitting there together, and I said, well, we've been sitting here now, and let's stand up and see what happens. So she stood up and she goes, yep, there it is. It's, sore in the front of the hip. Takes me a second to kind of like get it to like sort itself out. And then I feel, a bit better. I can move now.
Okay.
And so, she said, I don't usually, she goes, I guess I sit probably about maybe 10 minutes at a time. But she said, where it's the worst is getting out of the car, of course. Right, because that's where she spends the longest time sitting too. And then the movement to overcome inertia to get out of the car, is a big one. And then she started saying that, and every once in a while when I'm moving around in bed, I'm having some problems there as well.
Right.
So that makes sense.
So standing and walking were good. Stooping and sit to stand were not so great. Okay.
Right. So we did my very favorite thing to do, which is I just wanted her to bend over. I wanted to see how her spine moved and how her hips move and how her pelvis moved. She kept her head and neck in an upright and almost cervical lordotic position as she bent over.
Oh, interesting.
She didn't drop her head down. She did have a lot of thoracic flexion, not a lot of lumbar flexion, and certainly less hip flexion than I wanted to see. So she was and she uses the length of her body. She's got long legs. She's got long arms. She can get by with, get to the floor without having to do a lot of these things. So I just asked her, I said, do you have pain with that? And she said, well, I can kind of feel it in the back of my hip. I can kind of maybe feel it a little bit in the front of my hip. And I said, well, so we just stopped and I said, let's bend over again. And before I even started messing with her head, because that's another story, I just said, here at your pelvis, can you just bend your knees? And so she could bend, just let your knees bend. See if you can get your hands closer to the floor. So she allowed her knees to bend and her hips bent up beautifully, and she could put her hands on the floor. So it's like, okay, that's great. How does that feel? That feels pretty good.
And did her head dropped as well?
She kept her head in the same position.
Okay.
So we came back up again and I said, just one more time, what would happen if you curled all the way down? So I had her like drop her chin and, start to curl. And she said immediately that felt like it was pulling in the back of her neck. And at the same time, she said, I feel the urgency.
Oh, interesting. The minute she did that cervical flexion, the urgency came up. God, something's pulling up there neurally, right?
Exactly, right?
Wow.
And usually it's not that profound. I have to get into, a lot of other kinds of things to really get that to kind of present itself out. But it started right away with her, which was very interesting.
Wow.
So I said, okay, how far can you bend your head? So let's come out of that and see if we can get that to go away. Do you feel like you need to go to the bathroom? No, I'm okay. But that was the feeling I get. And I said, okay, so how far can you drop your chin before it comes on? So she kind of played with that, and it wasn't very far. So, which is very interesting because most people I find with this either don't move really well up there at all or they move a whole lot. So hers was more of a willingness to move, which was a lot different than, maybe something feeling stiff or, I just can't push past it, or every time I turn, if I see them bend their head down, they turn to the left or turn to the right or something a little bit. But hers was more of a willingness to move. So that, kind of throws up some cautionary flags, like whatever's going on is a bit sensitive up there and I'm going to be careful. I don't want to, freak her brain out by, going up there and grabbing hold of things and pulling them all around. So we just kind of let that go, and I said, let's do some other things. Let's stand on one leg. And so as she stood on the left, she actually kind of swayed way out onto the left side, onto the lateral border of her foot. But as she stood on the right side, she first of all couldn't figure out how to get her foot off the ground, and when she did, there was a lot of internal rotation and medial glide of the pelvis, or the hip medially under the pelvis. The old Shirley Sarman adduction, internal rotation glide, exactly. And that brought her urgency on.
Oh, so two things bring her urgency on. Very interesting.
So this usually I find one or the other, and this is kind of like, especially the first day. So we started, again, here we go. I'm going to do the Erica Mello thing. Is I went to the trunk and kind of like, let's start looking at the trunk and holding the trunk and finding, kind of where the driver is to this movement pattern. As soon as I got onto the trunk, she was able to she was able to stand on one leg without as much internal rotation, which was great. And but she was having a lot of difficulty, balancing at her foot. So as I got onto the pelvis, that didn't help it at all. It made it worse. And so I looked at that for a little bit more and kind of had her just play back and forth and just get a little motor learning going in there and see if she could, kind of straighten it up. And at the same time, I handed her a pillow and said, show me how you hold your son. And it was really interesting because she holds her son on the left, but deviates and rotates her trunk. She deviates to the right and rotates her trunk to the left. Which fits right into the pattern. So there's the pattern right there.
The movement pattern, right?
Yeah. And she does that because she uses her right hand to right, and that, so, okay. So then we just went over to the wall, put fingertips on the wall, and started working on just immediately, can you, coordinate, I just let her central nervous system figure it out. Can you re-coordinate and do it? As she did it, she got to the point where she could stand on one foot without the urgency.
Oh, that's awesome. Question. Did she, when you just took a look at her in standing, was her center of mass pretty central? Was she far to the left, or was she just, to the right, or AP, or
wider stance? And I've talked about that in my postpartum moms that I see, that they haven't brought their feet back together to, since pregnancy. They're still kind of out in that coronal based kind of wider stance. So definitely a bit of a wider stance and more weight shifted to the left, for sure, and just basic standing. So all the pattern fit, it all fits all the way through. What was interesting was when she got onto her right leg, the urgencies came on. I had to actually question her if she was having pain because the urgency took over. I mean, it was like that was a symptom she wanted to talk about.
Right.
And so I asked her about the pain. She goes, well, yeah, it bothers me a little bit, but she was telling me about the urgency more. So I just kind of let the pain piece go for a bit. Because I could have said, oh, well, we have an obturator internist that's probably overworking and blah, 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 blah. And it's like, let's see if we can get you to where you can stand and walk and not feel this urgency.
So what did you do? You placed her against the wall and had her do some glides?
Yeah. Actually, what I did was I just put her fingertips. I had her stand
facing the wall.
Yeah, put fingertips on the wall so that she, to kind of help change the, to take out a little bit of that thoracic rotation. And, because when you have your fingertips there, you can't really rotate too much to do the other. So she could kind of play around and begin to feel like, oh, gee, this is, hard for me. But she could re-coordinate it a little bit. But the biggest thing was I said, I want you to be able to do this in a way where you don't feel the urge. So that was like, I wanted her to pay attention to that. And because I felt like, I don't know, maybe it was the obturator internist, maybe it wasn't, maybe it's T12L1.
Right.
Maybe
Right.
it's something coming from the craniovertebral region. I don't know.
Right.
The urge can be so complex.
Right.
I also think that there's some constipation in there myself
Yeah.
because all that
Yeah.
coffee she's drinking and not eating really well.
Right. Right.
So it's multifactorial is my point. So it's like this
Mm-hmm.
was the first hot one that came up, and she was really like interested in this. So
Mm.
that's where we went.
Yep.
Meet the patient where they are.
Yeah. Yeah.
Let them
Totally.
drive the train
Yep.
because if they're going to take you organically to where they want to go and what they want to work on.
Right.
And so that's what, so I sent her, and then we did some squatting, and we just talked about, instead of squatting, why don't you just allow yourself to let your knees bend as you go to the floor to pick up your son? Allow your knees bend to, pick things up off the floor. She was just trying to keep her legs straight and bend over every time.
So, yeah, yeah. So when she has pain from sit to stand, so when she came up from a squatting position, did you notice anything there at all?
Not really.
Okay.
She was still kind of moving over to the left, but
Okay.
all of her patterns were over there. So I didn't want to fuss with too much stuff because, here's a new mom that evidently, as she's talking to me about pain, the urgency has risen to the top of the chart.
Yeah. Yeah.
So
Yeah. Yeah.
I wanted to figure out some ways for her to move that wasn't going to bring the urgency on.
Mm-hmm.
So I didn't
Mm-hmm.
worry about dropping her head because that just seemed, I felt like if I could get a couple of other things going better for her, that might change what's happening up at her head,
Mm-hmm.
and when she was bending her neck and the urgency would come on.
Mm-hmm.
So we just went over some stuff. We moved in bed and worked on some different things and added some exhale to
Mm-hmm.
automate up her system just a little bit and give her a little oomph so that she had a few things to work on. And the biggest one was sit to stand. I said, instead of just shooting straight up, why don't you just like lean forward a little bit and get into that position like when you're coming up from bending over to the floor, and
Mm-hmm.
then come on up and see how that feels. So we just kind of skirted around and looked at a couple of different movement patterns
Mm-hmm.
to kind of help her, do that with less symptoms. And she liked that, but she was really wanting to work on, that standing on one leg because she was intrigued by the fact that standing on one leg gave her the urgency and
There
that she could change it.
Yeah. Yeah.
So I asked her a couple of questions at that point. I said, at nighttime, when you're working,
Yeah.
when you're feeling this come on to the point where you actually leak, can you just, tell me just a little bit about, kind of what you're doing? And she said, usually I'm in the kitchen, and she's like making lunches or bending over, doing a lot of different things.
Mm.
And so there's, I
And
think there's a lot of head movement because if she's looking in the refrigerator and under the
uh,
cabinets and stuff like that.
is she holding the baby at all, doing any of that, or no?
No,
No.
it's only happening in the evening when everything is kind of quiet.
Oh, okay.
So
Yeah, where she's less distracted. So she's doing
mhm,
things, preparing, she's dropping the head. Oh, very interesting.
probably so. I
Yeah.
didn't bring the head up a whole lot more on that, um, because we were making some changes in a way that she was really excited about.
Mm-hmm.
So I left her working on one-legged stance. She knew what to do. She knew how to change it herself. She knew that she needed to get better at it. We did a little bit of, just postural sway and just gave her some variance around some typical movement patterns that she has throughout her day, with the idea that she needs to think about decreasing her coffee and increasing her nutrition.
Mm-hmm. Yeah.
And that's quite a bit. That's
Yeah,
a lot to swallow in one day and go home. So
absolutely.
I saw her 1 week later, and she came in and very happy with herself. She was down to one traveler's mug of coffee,
Mm,
and
that's
she
quick.
felt like that. She goes, I carry. So what she has done is she goes, once I finish, I clean it out and I fill it up with water, and I just carry it with me. I'm not really good about drinking the water all the time, but at least I've got it with me. So yay, we celebrated the victory and moved on.
Yeah, yeah.
She she had made some changes into her diet, and started, bringing in a little, making sure that she had a protein with a carb for her lunch and for her snacks.
Mm,
So, and she said that feels better to her by the afternoon. So two things: the coffee is down, which is also helping the afternoon fatigue,
yeah,
and the nutrition is up. So those are
yeah,
good things. So
yeah, yeah, yeah.
I'm happy with her, and she kind of has a little bit of a handle on that. So she's kind of forging ahead, and, with the resources that I sent her on that stuff. So that was good. So I asked her how the urgency was going. She said, well, this last week I had one incident in the evening, where I did leak, but she said, overall, I think I'm noticing the urgency more during the day because I'm starting to pay attention to it now. Whereas before I wasn't paying attention until I actually leaked.
Mm.
So she said, so she goes, I don't know if the urgency is better or not, but I'm noticing it because I'm focused on it. So,
Mm.
because we kind of, as
Yeah.
soon as she stood on one leg that one way, she said, oh, that's my urgency. She had
Right.
never really pulled those pieces together.
Tied the two,
So,
right?
yeah, so this last week was all about, okay, well, what if I do this? Does that make the urgency worse?
Right.
So and she said that I found that with movement, I could change it a little bit. So that was good. So we
Yeah.
talked a little bit about that. We looked at, she was able to really stand on one leg without having to put her fingers on the wall and do any of that stuff. She was very excited about that.
Yeah. Awareness is half the battle.
She could bend over and get things off the floor. She loved that. She was having less pain with sit to stand, mainly getting out of the car mostly as the time, because she just said, I'm just not sitting as much.
Yep.
When I sit for a bit and then I get up and move, and I'm just trying to keep moving because that seems to be better. So she's happy with that. So she still said, she goes, but I'm still having the pain with the sex, and I'd like to, kind of take a look at that. So I said, sure. So we did a pelvic exam, an internal exam, external internal exam, but basically looking at her hip, because I didn't get a chance to really look at the hip last time. And she does have less. It's interesting because when her movement pattern to stand is to go into full internal rotation. But when you flex her, she doesn't have internal rotation. It just is tight and it's painful.
Yeah.
And the left, she has full. And, I kind of thought, well, is this a structural thing, one leg to the other? Not really. I didn't really pick that up.
Yeah. Did you find anything internally at all?
Yeah. So she has a, overactive, obturator internus on the right. Mm-hmm. And it was painful to touch. I'm not terrible. I mean, it didn't like throw her off the table or anything like that. But the interesting thing was, because I know everybody out there listening, especially the women's health PTs, are going, oh, that's why she has pain with sex. And it's like, well, it's probably part of her urgency. But her pain, her real pain that reproduced the pain that she had with sex, was on the left side where the stitches were. The healed stitches were still very painful on that side. And that's what she said, that's it. That is what is keeping me from wanting to have sex right there. So we were able to talk about that a little bit, which was great. So I taught her some gentle, easy scar massage. And, we started talking about, tissue tolerance, and, that we needed to kind of begin to work to where, you can't go from 0 to 100, that your tissues have to be prepared for the event of sex. And this, this particular area just got a little left behind. Let's get it back on board here. And, we did some hold, relax stuff that she could do for her hip to calm, to gain a little bit more internal rotation in her hip and external and balance, the pelvis out. But I really feel like that, getting them on their feet and loading and loading, in supine, so some bridging and turning and those kinds of things do a whole lot more for balancing the hip muscles out around the pelvis than just doing like one motion pattern that really isn't an issue. And we talked a little bit about finding some different positions for sex. So that I said, so we looked at her hips and moving out into the missionary position, and she admitted that she said, I don't want him to push onto this hip, so I do kind of turn myself a little bit. Well, then that forces him right down onto that left scar.
Exactly.
Yeah. So she started seeing the combination there, and I said, so you guys can play around with some different positioning and do some different things, and get comfortable with that as you're able to, and just kind of, now that what's happening, that you'll be able to kind of take that to the bank and use that to the best of your ability. But I said that's why the lubrication didn't really help, because it's not a lubrication problem. It's a it's a sensitive scar. That's your brain is just kind of protecting that a little bit, and so being able to get that a little bit more mobile and feeling better to touch and stuff like that will help a lot.
Interesting. So from just for the listeners, range of motion perspective, no major limitations in the right hip. So her movement pattern was really into internal rotation. And so you basically gave her just some hold, relax things to do at home to get her out of that sort of compressive pattern and get her more open.
Yeah, exactly. Because that was her goal, was to, be able to be comfortable with sex and, not be worrying about that. And so nutrition-wise this time too, she admitted that her bowel movements have changed and that she was having, better, fluffier bowel movements. And she admitted, she goes, maybe I was a bit constipated. And I said, and you probably still are a bit, and it's going to take time for your colon to change lanes.
Right.
You know, you're still breastfeeding. There's still an awful lot of, you know, hormone things that are still in flux and changing. And so we just need, I said, behind every urgency pattern, there's usually some sort of GI driver. And, you know, so that's a piece of it. So this particular time, we left it at the pelvic floor and went. The third time she came in, we had the opportunity now to get into the craniovertebral region, which I thought was, you know, I wanted to kind of see, first of all, I knew what happened before. When she did cranial flexion, she brought her John. So we just kind of said, you know what, we haven't looked at a roll down in a while. Let's see what your roll down looks like. So she was able to go, she said, I think I can, because she remembered, she was playing around with it on her own. And she said, I think I can go further this way without bringing that feeling on. So I said, well, just show me then, that's fine. And I said, let's add the rest of the system to that. Just go as far as you can before it comes on, and then let's start to roll down. As soon as she brought the rest of the system in, it came on again. And the only way it would come off was by coming into craniovertebral extension.
Yep.
And so I asked a few questions again because it was like, why do we have this dural thing going on? This is a sign. This is a dural sign.
Yeah. No falls, no prior injuries, nothing.
Yeah,
right?
Nothing, right? She just said, you know, so I'm thinking, okay, this maybe, you know, got a system that has autoimmunity. We already know that. She already had times in her life with small joint pain and autoimmunity issues. And, you know, so I said, well, you know, let's just go with the fact that probably because of your migraines, maybe your central nervous system is a bit sensitized.
Was she fair-skinned?
Yeah.
Okay. That's also a factor.
Yeah, absolutely.
Yeah.
And very fair-skinned, as a matter of fact, you know, but not Scandinavian. Because I was starting to think, we have something, you know, what else could be going on here? Tall, you know, Amazon, but not Scandinavian. Kind of, you know, doesn't come from that background at all.
Yeah, I noticed the fair skin complexions is definitely, in my experience, a factor in some of these dural issues.
Yeah, absolutely. So I just said, you know, rather than trying to just figure out what was the mechanism, was there an injury or something, it was just like, let's sit down and let's play around with this just a little bit. So I had her, you know, stick her legs out and pull her feet back. And I said, just try to drop your head a little bit. Nope, that brought it back on again. It didn't bring on her pelvic pain. It didn't bring on any of the other stuff. It brought on the urgency. So we just went with that symptom. And then I just went through and did a neuroscan at this point. I checked reflexes. I checked, you know, pathological reflexes. I looked at clonus, Babinski. I did all the, you know, DTRs. I did some rapid movement tests and some other things. I just want to be sure. Let's make sure the system is clear. You know, nothing coming into the abdomen, so that was good. So nothing probably really getting stuck in the thoracic spine. You know, no, you know, but very interesting though that it would just take, as soon as we started to roll her up, it would come on. So it's like, okay, let's use that as a symptom.
Yeah.
And, you know, because I know people are thinking, you know, Susan, why didn't you go in and evaluate her craniovertebral joints? And it's like, I just, you know, my gut instinct was that wasn't going to be helpful at this point. What was going to be helpful was having her be able to get her nervous system moving in a way that wouldn't bring this symptom of urgency on.
Yeah, but if you stand and that's almost like if you're standing, you know, and you're dropping your head, that's a dural, that's neural. I mean, it's not like, you know, C1, C2, so, you know, that type of thing. You know, it's stiff.
Right,
it's the neural tethering. Something's tethering. There's
and also the other thing too that I think about with this, and I know you do this too, Erica, is, you know, to me, the willingness to move tells me if I should be moving them or not. And if I see somebody who's, and it's not, I'm not talking about a willful, you know, I'm just not going to move that way. I mean, you could just tell that she, you know, in the very beginning when I had her do that, the urge came on. So there was something driving her to not bend her head forward.
Yes.
Whatever it was. And so I don't feel like I should be doing anything manual at that point. If I can get it to change with her, you know, her being able to find a way to move and find easy ways to move that don't bring her symptoms on, we're going to go a lot further than me going in there.
Yeah, but it's interesting because the cervical flexion or the CV flexion and also standing on that right leg brought her urging. I mean, these are two very different movements, right?
Yeah, right.
What's the relationship there?
Yeah. It has to be the neural system.
Yeah.
It has to be.
Yeah.
So we got one part to get moving better. So now we needed to get the other part to get moving better, and then eventually get both parts to be moving better.
Mm-hmm.
So I just, with all the neural, tension sliders and gliders, I just used the head and neck and the lower extremities. I left the arms out at this point because I could light it up pretty easy with just, flexing into the spine, extending the knees somewhat, and she could work with her head, or she could work with her knees, and she could, just kind of, or even her feet. And so we just kind of worked up and down a little bit on the chain and got her to realize that I don't want you to push to the point of urge. I don't want you to keep motion testing that far, but I do want you to work into these positions without symptoms. So she could, begin to start to make some changes there and, and see what happened. One of the things that I didn't want to do also was have her be, yanking hard on her neck all the time, especially with a history of migraines. So, whatever she could do to kind of help desensitize that system was a good thing. And then I spent some time and taught her, which I hadn't been able to get to before. We did a little bit of restful breathing and some nice deep breathing, but I taught her a little bit more into the breathing world of, how to begin to bring her system out of stress. So we did, some different techniques to help her feel like, which one feels right to you, which one feels good to you. The one that she really liked was the combination of an inhale, a breath holding for a certain period of time, and then a nice exhale. And I just had her change the numbers up on that, like inhale for 2, hold for 4, exhale for 9. Inhale for 4, hold for 6, exhale for 4. I said, just change it up.
Yeah.
That seemed, she liked that a lot. So that seemed to help her change her system and do a little bit of relaxation. I just told her, I said, if you get a headache, just do some of this too, along the other things that you do, because it won't hurt, but it'll keep you from being like all, stressed out. And so I talked a little bit with her about the urgency, frequency, and stress system, and just that whole connection in there, so she could get the buy-in to, why do I need to do breathing when I feel urgency? And it's like, because it's a bit of a mind trick, so it takes your bladder out of its anxiety, if you want to think about it that way. But I said the other part of it is it just creates a different loop in your brain to like concentrate on, because now it's thinking about, what am I supposed to do with this breath, and it's going to let go of the the sensitivity around your bladder that's developed since your pregnancy. So
no, that's fantastic. So
so that's kind of where we are. So the next step is, for me, is to see how she is when she comes in, see if we've made some changes. Quite frankly, manual therapy wise, I still feel like I don't really need to be up and in the neck, but I feel like I can really influence it. So if I do any manual therapy at all, it may be to help get a little bit more rotation going, in her thoracic spine, see if we can't get some more movement patterns happening that way, and bring the arms into the, because I haven't brought in the upper quarter arms into the neural tension type sequencing. So I want to give her a little opportunity with that to continue to explore and get that central nervous system moving in a number of different ways.
So when you did the sitting with like the slumping, right? When the urgency was brought on, how did she get rid of that? Did she just put her neck, her CV extend? I mean, she just didn't flex her upper cervical, correct? And that was fine.
Right. So that was one way. The other way was I would just have her bend her legs, bend her knees slightly.
Okay.
So she could come into it a little bit with some head flexion, and her knees were straight, or her toes were back in dorsiflexion. So I'd start lower and see if we could influence it from the lower end.
About taking tension off, the
right,
lower
because
quarter.
like I said, I didn't want to jack her neck up. I just didn't want her always being so hyper focused on the neck. I wanted to see if we could influence the whole system from below too.
Question. So was her head, just from a visual, was it like Bert and Ernie? Like the Bert and Ernie heads. Was hers more like oval or round?
Oval.
Oval. Okay.
Hmm.
So I found that sometimes if you see, especially with some of these complicated patients with who have dural issues, the shape of their, I know it sounds crazy, but I found I've
Hmm.
learned this like in a couple of LJ's courses. They just, when you are like one head position or one head shape, sort of sucks in like a turtle almost. When you're like, if you have them lying supine on the table in hook lying and your hands are under their head and you're just doing like a little bit of upper cervical flexion, when you have them straighten their legs out, it's almost like you feel their head getting sucked into their body, down
Hmm.
into their
Hmm.
thorax. And I see that a lot in patients who have dural issues or upper neck issues, and it's usually with these Bert and Ernie heads. It's weird. I can't explain it, but their head shapes, for me at least, make a difference in some of those
And
cases.
it's super interesting that you bring that up because I'll just share with the audience and with you right now that one of the things that was needling in the back of my head was Chiari malformation
Mm,
with the
yes.
headaches and the dural
Yes.
tension
Yep.
and the stuff.
Yep.
But the ace in the hole that I have with her is that she has a neurologist on board.
Right.
So
And
she is working with her neurologist, and she has told me that they have ruled out
yes.
some
Right.
of these things. So
Yeah.
this is good. I didn't have to send her for stuff.
Yeah.
She already had it. But I just, that was one of the things that kind of like, ooh, why is that happening? When she bent her head down, it was like, I
Yeah.
wonder, because you brought it up to me, because that whole feeling of being sucked down into your body, that's
Yeah.
that's a herniation of the brainstem into the
Right.
foramen magnum,
Right.
and can cause all kinds of crazy stuff.
I know. I know.
Really can cause all kinds of crazy stuff, but those things were ruled out. So that's good. And she's still actively working with the neurologist. So she is going back to see, I do a side note, she is definitely going back to see her endocrinologist. And I told her, I wrote down a few things for them to look at. And I said, let them, figure out the other stuff too. But if somebody hasn't done a full thyroid panel on you now, they need to.
Yeah. Yeah.
And take a look at the other things, make sure your B's are up and your D's are good, and some of the other stuff. And I said, and they'll do the C-reactive proteins and the other stuff that they need to do. But
Yep.
I said, be sure that they actually take a good look at a full, not just T3, T4, but a full thyroid panel, including
Yeah.
antibodies. And let's just make
Yeah.
sure
For
your
sure.
thyroid's good.
Yeah. So for the listeners, in terms of home exercise, you basically started off with that isometric in the hip, and then just being more aware
Mm-hmm.
of her positions during the day. Anything else? Oh, and was she doing the things against the wall as well with her fingertips on
Right,
the wall?
right. So week 1, we were working on the single leg stance because that brought on her urge. So we
Yep.
were changing that. So yeah, she was working on, whenever she could, fingertips on a countertop, fingertips on a wall, wherever she could, just kind of just start seeing how you can shift your weight and do it without that coming on, and making sure that you're getting your muscles to kind of turn on a little bit differently. Because I basically wanted her to be able to stand on one leg or the other leg without having to do all this shifting and have all these symptoms come on. So, and and then we went to bend overs, but having the knees bent so she could actually close her hips up, because
Got
one
it.
of the things she was worried about was she felt like it was the bending was what was making her anterior right hip pain worse. And by demonstrating that bend over with her knees flexing, she could get her trunk all the way down. And I mean, she went into
Hmm.
full hip flexion and she didn't have symptoms.
Right.
So she could see that, oh, it's not hip flexion that's driving this.
Right. Right.
So I had her move in some different ways like that as well to get that going. Then the next time I saw her was when we looked at the pelvic floor and the pelvis, and that's when we added the hip, some isometrics in for hold, relax, and to just get her to
Yep.
be
Yep.
allowing of movement there. And then we talked about scar massage and change
Yes.
positions for sex.
Got it.
And in the meantime, the coffee's coming down, the nutrition's
Yep.
coming up, and then the third time she came in, we started working through the neural tension system.
Yeah.
And so
Yeah.
now those neural tension gliders and sliders are her exercises.
Yeah. For
Right?
sure.
I stayed out of tensioners because I didn't want her to be in a position where she was tensioning and getting the symptoms. So
Exactly.
we were just moving and gliding in and out of those, and
Yeah.
more emphasis on the lower quarter being the driver for that than the head.
Right.
Right?
Got it. Yeah. 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 Of course.
Yeah.
Yep. Yep.
And so
Yep.
then finally, like I say, where I want to go is adding the arms into the system.
Yes.
I didn't add the arms in because it was complicated enough with just the legs and the head. So keep her
Yeah.
going that way and
Yeah.
see where
Yeah.
she is. So the other thing is too, is that I gave her a link for some dilators and to help her with, I'm going to teach her the next time she comes in, she's scheduled to teach her some good stuff about using the dilators to help her with her scar sensitivity, and to help her with, just sensitivity around the whole perineal area, as far as, different sizes being able to be inserted without pain.
So in terms of that, obturator internus, not necessary to look at, not necessary to treat manually directly.
I didn't feel so. I didn't feel so. First of all, it didn't recreate her pelvic pain, her pain of any kind. It probably had something to do with her urgency, but I felt like that the obturator was going to be, the overactivity obturator would change with the exercises that she was doing for the one leg stance and the bend overs, and we're going to work on squats the next time too. I want to get some eccentric loading into this system as well. Once she can start tolerating more of these movements with her head in a different position without the urge, then I definitely want to get her loading and going for sure.
It's interesting.
No,
it's interesting because I think this is a great patient, because to look at as an example of like the whole body movement pattern. So for example, so the nervous system, when you have issues with the dura or any kind of neural system, the body, if there's one position they don't like, they'll take tension off somewhere else, unconsciously, right? And with her, it was obviously her upper neck, and she would never get herself into a fully loaded position in terms of tensioning the nervous system, because that would bring her symptoms on. And she just unconsciously decided to adopt either, upper cervical flexion, bending the knees, whatever it was. The body just does, I don't like this, I'm going to take tension off somewhere. And they do this unconsciously.
Which kept her into that craniovertebral extension.
Exactly. And that is the relationship between the right hip and the up and the neck, because the body is just protecting itself. It just does something. It's you see this a lot. I mean, it could have been her foot was inverting or whatever, or it could have been at her shoulder, but it happened to happen. It happened at her neck, and the body is a beautiful thing that way until we run out of options. And I think that people who have dural and nervous system issues tend to be, I mean, I have a similar issue with headaches like her, and I think we basically just want to just cocoon, and we just do something to take tension off somewhere in the system, and this is a really great patient that demonstrates the holistic, literally from soup to nuts, looking at the whole body,
Yep.
So
lots of good stuff today.
Yeah, that's awesome. Well, this is great. Please keep us updated. I know we have to do a podcast that says, where are they now?
Yeah, I think we'll start scheduling a few of those.
Yeah, for sure.
As we go forward, because I know we have a few to report on that you all would be interested in, kind of how they're doing and where they tripped up again in the, after we talked about them, and how we got them back on track a little bit and some things like that. So we will definitely start looking at doing that now that we have about 35 of these out there. We want to kind of circle back and see if we can't take a look at some of these in series too as well.
Yeah, absolutely.
So yes, thanks for listening, everybody. As usual, I look forward to your remarks, your questions. Please find us on iTunes or Spotify or Stitch It or YouTube. All the other places where we YouTube. Yes, we have a YouTube channel. So if you don't have all these other things, you can always listen on YouTube. And we do have a website. So that's good. Come to our website, because we have some opt-ins for you there. And we'd love to have you on our email list, where you can hear about different exciting things that are going on out in the PT world with us besides our podcast. So
yes, and I think we're going to put up a resources page, because people ask us all the time about resources for courses and videos. So that's a work in progress, people. So just be patient.
We're getting there. We're getting there.
We are. All right. Thanks, Susan. Thanks, everybody.
Yes. Thank you, everyone. Have a great day.
Bye.